Good afternoon. This is the last run rounds for the year. Can you all hear me okay in the back? Can everyone hear me okay back there? Okay. So my talk is on insomnia in the older adult. And with this being the last grand rounds, if anyone has their eyes closed, I'll assume that you're doing research. Fair enough? Okay. So within the past year, there have been 2 guidelines released for the management of insomnia. One by the ACP, which is more for primary care providers, such as myself. And it's sort of a general overview, and they really don't make any recommendations on specific pharmacotherapy. Whereas the other is by the American Academy of Sleep Medicine, and they actually go into the pharmacotherapy in a little bit more detail, and which I found it to be very good for us to know in primary care as well. So both guidelines, they use the grade methodology, looking at the quality of evidence as being high, moderate, or low. Also the strength of recommendations, being strong meaning the benefits clearly outweigh the risk, or the risk clearly outweigh the benefits, but there's a clear difference. Or weak, meaning that there's a sort of a fine balance between risk and burden. Some of the key factors in deciding on a strong or weak recommendation are the quality of evidence, values and preferences, the benefits of therapy, the harm of therapy, as well as the cost. And I put this in here just as a reminder when we get to the end, because some of the recommendations, I was like, wow, we've been doing that for a long time. Was I doing that the wrong way? But you have to remember that it's based on the strength of the recommendation. And a lot of things that we've been doing are actually considered to be a weak recommendation. So when we think about sleep, sleep is divided into non-REM and REM. Stage 1 is the transition to sleep. Basically, you're drifting to sleep, easily awakened. The heart rate starts to decrease, and this is about 5% of your sleep time. Stage 2 is the deeper sleep, and it's a larger percentage of the sleep time, and there's even more of a decrease in the sympathetic drive. And then stage 3, that is your deep or your slow wave sleep. And again, sympathetic drive decreases more, blood pressure decreases, and this is about 15 to 20% of your total sleep time. Those are your non-REM stages. And after that, you go into your REM stages. That's your rapid eye movement. Actually, this is the time where you have dreams, but the muscles are basic tonic during a lot of part of this time. And this is about 15 to 20% of the sleep time. So what happens with aging as far as sleep architecture? Well, the time in stage 1 and stage 2 increases. So older patients actually spend more time in the lighter stages of sleep and less time in the deeper stages, the stage 3 and the REM. And so as you saw in the first slide where the sympathetic drive was continuing to decrease, but actually older patients are actually spending more time with the elevated sympathetic drive. What about sleep quality and duration with aging? So the total sleep time is decreased. For example, a child may sleep 14 hours a day, whereas an older adult may only sleep 5 to 6 hours. Also, sleep efficiency is decreased. That's a percentage of the sleep time compared to the total time in bed. A lot of times the sleep is fragmented due to other comorbid conditions. And then the daytime sleep latency is also decreased. They fall asleep faster during the daytime, and at night actually it takes a longer time for them to fall asleep. There are circadian rhythm changes with aging. One thing is a phase advancement, where they wake up earlier in the mornings and then are sleepier earlier in the afternoons. Melatonin levels, they also decrease with age as well. And, melatonin is also involved with regulating the sleep-wake cycle. Then you have your suprachiasmatic nucleus. This is considered to be the master clock of the circadian rhythms, and it starts to deteriorate with age as well. So chronic insomnia disorder is, according to the DSM-5 and the International Classification of Sleep Disorders, is defined as difficulty initiating sleep, maintaining sleep, or waking up too early. There's an adequate opportunity for sleep. And there's also deficits in daytime function. This is not better explained by another sleep disorder. This occurs at least 3 times per week for 3 months. And according to those definitions, the prevalence is about 15%. The ICD-10 defines insomnia according to the older way of organic versus non-organic. And so, again, it's difficulty falling asleep, maintaining sleep. It's basically a non-restorative sleep. There's a preoccupation with sleeplessness and just excessive concern about not being able to sleep during the night. And also they worry about this during the day. Now this is considered to be at least 3 times a week for 1 month. And the prevalence is about 4%, and that's the ICD-10 code. So some of the deficits in daytime function, fatigue, worry about lack of sleep, again, poor concentration, increased accidents. And for some of the younger folks and older folks that are still working, there's a significant absenteeism. One of the studies showed that the economic impact was about $63 billion in 2009. So who's most affected by insomnia? Older adults, patients who have comorbid medical illness, patients with a family history, also women. The prevalence between men and women, it starts to get higher for women, especially during the postmenopausal period. Also people with in lower socioeconomic status, night shift workers, people that are caring for caregivers that have frequently get up during the night, and also people returning from military deployment. Yesterday was Memorial Day, and there's as far as veterans returning from Afghanistan, they think it's about 40% of those suffer from insomnia. So this is one of the studies that looked at the prevalence of insomnia by age group, and you can see that the prevalence increases with age, and the highest prevalence is in the 65 to 79-year-old group. When we mentioned comorbidities earlier, there is a relationship between the prevalence and the number of comorbidities. You can see that the more comorbidities you have, the higher the prevalence of insomnia. And actually this study looked at 4 or more as being the highest area. So what are the insomnia issues in the elderly? One is underreporting. Many of our older patients just feel like not getting enough sleep or not being able to sleep at night is just a part of aging. Also, many of our older patients will frequently take naps during the day, and so some of the symptoms may not be as exaggerated. Then there's usually a delay in receiving a formal diagnosis. We see a lot of the patients in the clinic, and we're thinking, oh, well, it's a hypertension or they're cardiovascular disease, and so we're really focusing on those, which as we should. But and then again, as we mentioned, other comorbidities. But our elderly patients are also at increased risk for falls due to the sleepiness, the deficits in the daytime function. There have been a number of comorbidity studies, and I'll just highlight a few, but they showed there's an association between insomnia and elevated cardiovascular risk, and this was even after adjusting for potential co-founders. Also, a decrease in the total sleep time was associated with increased hypertension, and they found that once the insomnia was treated, the hypertension actually improved. Also, the same was for diabetes. Glycemic control was better in patients once their insomnia was treated. And then there's a bidirectional relationship between insomnia and depression. And so many patients with depression who also have insomnia are at a greater risk for suicide. So this is what they call the 3P conceptual model of insomnia in older adults. You have predisposing factors such as physical and mental health, family history of insomnia, again, the lower socioeconomic status. So that starts here. And then there's a precipitating factor, such as an older person being hospitalized, loss of a loved one, or going to a nursing home. So once those precipitating factors happen, it sort of crosses the threshold into insomnia. And then you have the perpetuating factors, which is the daily behavior, sort of the worry about not being able to get enough sleep. Again, being in a nursing home, losing the loved one. And so they're just like, I'm not sleeping, it's a new environment. And the behavioral and emotional influence are the target of the cognitive behavioral therapy that we'll talk about later. So when we talk about diagnostic evaluation, it's a clinical diagnosis. We see a lot of it in the medicine clinic. A good sleep history will make or exclude the diagnosis. You want to get a detailed description of the sleep problem. When are they? How many times are they waking up? When are they going to bed? What do they think is disturbing their sleep? What's the environment like? And then also associated conditions or medications. So this was another study, and it showed that like 90% of chronic insomnia was associated with other medical conditions. We see angina and arthritis are common complaints as far as the cardiovascular and musculoskeletal areas, and we see that commonly in a general medicine clinic. Also patients with GERD, diabetes, COPD, a lot of urinary complaints as well. And all of these have been associated with chronic insomnia. So when we look at the medications, antidepressants like your SSRIs, stimulants that make sense, caffeine, decongestants, the pseudoephedrine, the phenylephrine. A lot of our patients are getting over-the-counter medicines. Narcotics, or oxycodone, codeine, as well as your cardiovascular medications, beta blockers, the alpha receptor agonists and antagonists, diuretics, getting up during the night to go to the restroom, and even your lipid-lowering agents. Also, when you think about pulmonary, your theophylline as well as your albuterol. And alcohol is actually the most common substance that's used to self-medicate for insomnia, but it also contributes to the insomnia. So I won't go through all these questions, but this is an example of a sleep diary that you can give your patients. And it's they'll fill this out for about 2 weeks and kind of answering some of those questions. It just supports the diagnosis and management. And if they end up going to a sleep specialist, it's good to already have this ready for their office visit. The Annals of Internal Medicine also published this article, and basically they focus on the Insomnia Severity Index. It's a validated scoring tool. You have 7 questions, and they're scored. If it's greater than 15, it's considered moderate severity. Greater than 22 is considered severe insomnia. And this is, again, used to support the diagnosis, but also it's used for the sleep specialist or to adjust the treatment as well. So coming back to the guidelines, so the ACP recommended cognitive behavioral therapy as well as the AASM. This was moderate quality evidence, but a very strong recommendation. And so this was the first thing that was recommended by both groups. So it's been shown that 50 to 75% of patients have significant improvement with cognitive behavioral therapy. The problem is trying to do it in a primary care clinic. There's not a lot of providers are trained. And I actually went on the National Sleep Foundation website and just kind of put in our zip code here, and it came up with like 2 providers within a 50-mile radius. So one of the ways to get around that is the internet, and this was one study that was actually done in younger adults, but it showed that CBT delivered by the internet was an effective method of delivery. But again, this was younger adults. And then more recently, around April of this year, there was another one that did mobile phone delivered CBT, and that may be a little bit better for our older patients. Seems like everyone has a cell phone now. So the components are sleep hygiene, education, stimulus control therapy, cognitive therapy, relaxation therapy, and sleep restriction therapy. You can kind of read over some of the rules for a good night's rest, but basically this focuses on a healthy lifestyle. Sorry, I thought this was off. Basically, it focuses on the healthy lifestyle practices to improve sleep. And you want to use this in conjunction with the other ones, such as stimulus control, relaxation training, sleep restriction, and cognitive therapy. And then when we look at stimulus control therapy, it's really to extinguish the negative association between the bed and the undesirable outcomes, such as the excessive worry about not being able to go to sleep. And I found this kind of ironic. Number 5 says not take a nap during the day, but with the phase advance and many of our older patients, they frequently will nap during the day. It's not recommended. Cognitive therapy seeks to change the patient's overall values and beliefs and their unrealistic expectations about sleep, such as I can't sleep without medication. If I can't sleep, I should just stay in bed. My life will be ruined if I can't sleep. So cognitive therapy tries to really reduce the catastrophic thinking and address those issues. Again, and the last component was the relaxation therapy, and this serves to kind of lower the somatic and cognitive arousal states, as I kind of mentioned in the first slide. And they do the progressive relaxation of the muscles to try to control the tension, also guided imagery as well as meditation. Well, one more, sleep restriction therapy. So if a patient says they only sleep for 4 hours per night, then the sleep specialist will tell them just stay in the bed during those 4 hours, and then they'll have them get up, and then they'll gradually sort of increase this, but really it's restricting their sleep to just the time in bed. And it's maybe okay for older patients, but you have to think about occupational hazards with some of the younger patients, such as pilots and truck drivers. So when it comes to pharmacotherapy, you see that the largest group, this is from the NHANES study, but the largest groups using prescription sleep aids in the past 30 days were the adults aged 80 and over. So it's pretty significant. So the ACP, the second recommendation was that if the CBT doesn't work and you're thinking about pharmacotherapy, this needs to be a shared decision, shared discussion. You want to discuss the benefits, the harms, the cost with your patients as well. But this was a weak recommendation, and it was low quality evidence. So really, they really favor the CBT. And also the FDA has approved pharmacotherapy really for just short-term use, like 4 to 5 weeks. Now the American Academy of Sleep Medicine, their practice guidelines, went more into the pharmacotherapy, and we kind of had to extrapolate for older adults, but in general, the guidelines are usually appropriate for older adults as well as younger adults. You have to lower some of the doses in the older adults. And then you have to remember the potential side effects and drug-drug interactions as well. And again, these were all weak recommendations. So the first recommendation was 4, and it was actually for benzodiazepines. Remember, weak recommendation was still 4. Then the benzodiazepines, they bind to the GABA receptor. This inhibits the neuronal excitation, and it decreases the time to sleep onset, prolongs the stage 2 of sleep. You have an increase in your total sleep time and decreased anxiety. And temazepam, 7.5 milligrams, was the dose that was recommended in the elderly. Now the caveat here is that the benzodiazepines are on our Beers list. And so some of the side effects are residual daytime sedation, cognitive impairment, they're habit forming, you worry about the rebound insomnia, as well as the anterograde amnesia. And especially in our older patients, we're concerned about the increased risk for falls. The second category was the benzodiazepine receptor agonist. This is your zopiclone, zopiclone, and your zopiclone. Now these are better targeted to the GABA type A receptor, so they're better targeted. So you have decreased sleep latency, decreased number of awakenings, sleep quality and duration is improved. The side effects, because since they're better targeted to the receptors, the side effects are less frequent and less severe, but they're still present. And one of the big things with the side effects here was the complex sleep-related behavior. I had a relative that was actually on one of these medications, and every morning her porch was wet, and couldn't figure out why is your porch wet. And so finally we had another relative that stayed the night, and she said, why are you watering your ferns at midnight? And so, and she was actually on one of these medications, and that's considered one of the complex sleep-related behaviors. Again, zopiclone, half-life is about 1.5 to 2 hours. It's good for sleep initiation insomnia. There's an oral spray. Some of the side effects are headaches, dizziness, and increased somnolence. There's a dissolvable tablet, and the lowest dose for women and elderly is 5 milligrams, and this was from a 2013 FDA communication. They found that about 15% of women and 3% of men had doses that were higher than 50 nanograms per ml. and this was like 6 hours later, and so they recommended a lower dose. And if you're going to use the extended release, the recommendation is that you use 6.25 milligrams. The zopiclone has the longest half-life, and especially in older adults. Half-life can be as long as 9 hours. This is effective for sleep maintenance. One of the issues is a metallic taste, possibly habit forming, and then this was recommended a starting dose of 1 milligrams. Again, this was a 2014 FDA safety communication as well. They found that impairment in driving, memory, and coordination actually lasted more than 11 hours in those patients that were taking 2 and 3 milligrams. So the melatonin agonist, Remaltion, actually had fewer side effects versus the non-benzodiazepines. This is a weak recommendation for. It's 8 milligrams every night. This is, again, more effective for sleep onset. There was no associated next-day residual performance deficits, and it's not a scheduled substance with the DEA. And all that sounds pretty good, but it's like $280 a month. It's very expensive, and we said the greatest risk factors were patients that had lower socioeconomic status, and sometimes it's a struggle to get some of the insurance companies to actually pay for it. So the reason I keep saying weak recommendation was because of this. Sedating low-dose antidepressants, doxepin, and for those of you taking the boards, this is probably something that you would want to be familiar with, but doxepin is the only antidepressant that's approved by the FDA for the treatment of insomnia. It's 3 milligram dose in the elderly, and it's good for sleep maintenance and insomnia. Now, throughout my residency, we always used trazodone, but the new guidelines are saying it's not recommended, and says that the low dose has increased histamine effect, increased drowsiness, and you worry about orthostasis risk. Again, weak recommendation, but I was really kind of shocked to see that. So the orexin receptor antagonist, suvorexin. So orexins are neuropeptides in the hypothalamus that are thought to stimulate the sleep-wake cycle, particularly wake. And so these are antagonists for that. And this was approved in 2014. Max dose in the elderly is 15 milligrams. Good for sleep maintenance. You have to watch in patients who have liver disease. And there's an increased risk for dependence and abuse. And again, this is also very expensive as well. It's like about $250 a month. Whereas the trazodone was actually very cheap. So now, when we discuss what's not recommended, anti-epilepsy medications like the gabapentin and the ticagrelor, which we don't typically use that one anymore, but these were not recommended for primary treatment of insomnia. If you were treating the epilepsy and the sedative effect is good, but not for primary treatment. Barbiturate type drugs, and chlorhydrate, some of those are actually FDA approved, but according to the recommendation from the guidelines, they're not recommended due to low therapeutic index and safety issues. A lot of our older patients are using the over-the-counter antihistamines as well, and again, they're listed on the Beers list, and there wasn't enough evidence to recommend those as well. Another thing that I was surprised by when we look at the herbal and nutritional substances was the valerian and the melatonin. They didn't recommend that either, which I was surprised, but they said that there wasn't enough evidence to say that the benefit outweighed the risk for those, and so they were not recommended. And again, weak recommendation. But I kind of say to you, if you have a patient, low socioeconomic status, they can't really afford the $280 for the Remaltion, but they can get over-the-counter melatonin, and the evidence is sort of balanced there almost. And then many of our older patients will kind of take their chances with those. So that went a little bit faster than I thought, but do you have any questions? Okay. Thank you. Enjoy your summer.